Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attended with bilateral benign osteonecrosis. And I'll explain what that is during the course of the video. So this is the patient's left ear. It's not fully occluding, it's an opening at the roof of the ear canal, hence why I'm beginning the procedure using the right angled ear hook. But as soon as I try to bring this out, it just kind of cut through it. But this patient is a regular patient. They come every year, 18 months. So I already know they've got this condition called benign osteonecrosis. And essentially what we need to do is elevate skin from a widening that's accrued at the bottom of the ear canal as a result of their pathology. So benign osteonecrosis is when the temporal bone, and more specifically the inferior portion of the temporal bone. So the temporal bone is the bone that encompasses the ear canal. And in cases of benign osteonecrosis, it's the inferior canal wall, so the bottom part of the bony part of the ear canal, that essentially decays away, and the bone can also separate from that region, and that's called sequestration. And it's typically due to patients, elderly patients, who have a history of hypertension, so high blood pressure, and if also taking bisphosphonates medication, typically for osteoporosis. Let me explain the pathophysiology. So if you have hypertension, you have a high blood pressure, so it damages the inner walls of your blood vessels, which then become more stiff and less elastic. And that encourages the buildup of fatty substances, so plaques within the blood vessels. We call that arteriosclerosis. And the net effect is that you've got reduced blood flow. And therefore, the blood reaching the bottom part of the bony part of the ear canal, so the inferior part, is starved of all the oxygen and nutrients that the blood supply provides it. And as a result, it leads to the death of the bone, so it begins to decay, and then occasionally that bone can literally separate, and we call that sequestration. And it creates a massive crater, a widening at the floor of the ear canal. So it's a different pathology to an external auditory canal cholesteatoma, and that's when you have a dead skin cyst that forms in the ear canal. And with cholesteatomas, they release lysosomal proteolytic enzymes, which are basically digestive enzymes. They chew away at flesh and bone, and then you have bacterial involvement in those cases of an external auditory canal cholesteatoma, which similarly release proteolytic enzymes, which again further start chewing away at the flesh and bone. And it also differs from a keratosis obturans. So keratosis obturans, when you have a plug of epidermal skin, so the outer layer of skin that sheds from the ear canal, it abnormally sheds, forms into a plug, almost like a rubber ball, and then it completely occludes the ear canal, and it compresses against the walls of the ear canal, and the compressing against the walls of the ear canal instigate and initiate a process called bony resorption and bony remodeling. And in cases of keratosis obturans, the widening is global, and when we say global, we mean it's all the way around the perimeter of the ear canal. With benign osteonecrosis, it's almost exclusively at the floor of the ear canal. And quite often in cases of benign osteonecrosis, the ear canal is not blocked, like in this case. With an external auditory canal cholesteatoma, typically you have an ulceration of this as well, so the skin that's lining the floor of the ear canal, or again, with an external auditory canal cholesteatoma, it's kind of a local destruction of the ear canal wall, but it doesn't have to be at the floor. Typically it does occur at the floor, but it can also occur at the front wall of the ear canal, the back walls, or the anterior and posterior canal walls. There's typically discharge associated with an external auditory canal cholesteatoma, And quite often in stage 2 and stage 3, you have an ulceration. So the skin that lines the ear canal has also been basically chewed away and the underlying bone is exposed. In most cases with a benign osteonecrosis, the skin is not ulcerated, so it's still lining the bony part of the ear canal. But I have seen cases where there's also an ulceration there. And in terms of clinical symptoms, typically patients just feel that their ear is getting blocked, so there's some oral fullness and a lot of itchiness and irritation in that region of the ear. I mentioned another risk factor, and that's patients who take bisphosphonates, and typically they're provided to patients with osteoporosis. And I believe the reason why that is a risk factor is because in cases of osteoporosis, what bisphosphonates do, they inhibit the function of specialized cells that live on the surface of the bone called osteoclasts. And what osteoclasts do, they basically break down the outer layers of bone into its kind of core minerals and tissue and recirculate that via the bloodstream to other parts of the body where new bone can then be formed using the minerals and tissues that have been broken down. So what bisphosphonates do, they basically inhibit the function of the osteoclasts. So that outer layer of bone is not being basically broken down, and whilst it's not breaking down, other specialized cells called osteoblasts are generating new bone. So I think it's basically designed to increase bone density, but it can make the bone more brittle, because the recycling of the outer layers of bone is quite important actually, because they're more exposed and there could be bacteria living on the surface. By recycling the outer layers of bone, you're basically getting rid of any pathogenic bacteria that may then cause other problems. So the regeneration of new bone and the recycling of old bone is actually quite an important process. So with bisphosphonates, although it can increase the amount of bone you've got because it's not shedding the outer layer and recycling it, it can make that bone more brittle because there might be some bacteria, for example, or that bone is over time it's degenerated itself. And that I think bisphosphonates also causes problems with patients' jaws and their temporomandibular joint. So other potential causes is patients who have undergone radiotherapy around the ear or head. The radiotherapy can damage blood vessels, and of course when you've got damaged blood vessels you've got poor vascular supply. So once again, the inferior portion of the ear canal, the bone, is starved of all the blood, and obviously the blood transports all the nutrients and oxygen that it needs to sustain itself. So in terms of treatments, sometimes in really extreme cases, the ENT can perform surgery, so they can kind of introduce temporalis fascia muscles to thicken that region and reintroduce periosteum. So periosteum is a thin membrane that sits on the bone, and actually it's the periosteum that supplies the blood to the bone. So to revascularize it essentially. But prior to doing that, they put a muscle graft to fill in the erosion. Hyperbaric oxygen therapy, I've read that sometimes is used. Not only does that increase oxygen, but it can also help kill any gram-negative bacteria, which are the harmful bacteria in the ear, basically. You get gram-positive and gram-negative bacteria, and gram-negative bacteria are typically the more pathogenic and the more serious. It's not to say that gram-positive bacteria are not, but it's normally the gram-negative you need to be more wary about. And hyperbaric oxygen therapy also promotes the neovascularization, the formation of new blood vessels. So what we're doing here, I'm just trying to lift this from the floor of the ear canal. I'm using various instruments. I'm using the ear pick here. I've used the correct, the ear hook, and forceps and suction now. There's some bleeding there, but that's not because we've scratched the ear canal. There's just some granulation tissue formed. So granulation tissue is inflammatory tissue, and it's essentially connective tissue that forms as part of the healing process or inflammation process. And this connective tissue forms its own blood capillaries. So it has its own form of neovascularization. And when you're removing adhered skin and wax, here you're going to rupture these blood vessels that are formed in the granulation tissue. So another term for that, I think it's called contact bleeding. But yeah, there's no, we've not caused trauma to the ear canal. And in their right ear, which is far easier to clean, you'll see some granulation tissue there as well, which wasn't ruptured. We managed to remove it without rupturing it. You can see I'm really trying to pull this out the trench. And the skin is so adhesive. It's so adhered, it's extremely difficult. In fact, I'm pushing it towards the eardrum in order to lift it up. Now that I've lifted up, and you can see some granulation just on the right hand side, about 1 o'clock on screen, on the edge. So I'm just wriggling this out. And in cases of benign osteonecrosis, the best treatment really is just regular cleaning of the ear. Hence why this patient tends every year. So, and you can probably see the border of the old ear canal. You'll have some more views. Now what I want to do now is just peel away just as much skin as possible. And there was a layer of skin on the eardrum, I think, which also came away when I removed this plug. So just where I am now, that's the border, the perimeter of the original ear canal, and anything, it's almost like a cliff edge. I don't know if you can see that. Just where I am now, just before the ear canal kind of comes down, and that's the widening. Again, this skin is extremely thick. I'm just going to lift it up. I did use forceps in the end. So whilst this patient's here, if I just clean as much as possible, and they've been coming on a regular basis, they're really comfortable with what we're doing, so it's worthwhile. And they travel a fair distance to visit me as well, so I just wanted to get as much out as possible, as safely as possible, so we're not going to get every little last speck out. So I think this is where I used the forceps. So you can see that huge widening. I have got patients with even larger widenings than this. Now guys, I just want to bring up a quick point. So we regularly get people emailing us with videos of their ears, asking us to basically provide a consultation for them, some advice. And unfortunately, we can't offer that service, and it's for a number of reasons. First of all, fundamentally, I'm a private company. I'm not ashamed to say that. I mean, that's how I don't work for the National Health Service, so we're not NHS funded, we're purely private. So if I start giving advice away for free like that, it's not really fair on my patients. My patients obviously paying patients, and I would then have to basically offer that service to everyone. It's not right that a patient comes to see me and pays, and then at the same time I'm giving advice to someone else for free. It's not really ethical, which will basically mean if I give everyone free treatment, well, I don't have a business, and so ethically and morally we can't do it for that reason. Then there's insurance reasons. Thirdly, some of these quality videos is really, really poor. And fourth of all, if I was to respond to each and every case, I wouldn't have time to run my business and see my patients. So we do have a prepared email script, and we often obviously we could just ignore these emails, but we decide not to, because we want to reply and be polite, and we do explain in the emails the reasons why. Obviously some people don't respond back, but majority of people do actually respond, and they understand. It's okay, yeah, we didn't see it in that way, totally understand. But just occasionally we've had some people reply back being really, not really nice and unpleasant, or having a parting shot. So we had one today basically insinuating that, I should be doing it, it doesn't take long, and any reputable company would do it. And that's not the case. I mean, if I work for the National Health Service, that's completely different. But I've got a business to run. I've got rent. I've got utilities. I've got insurance. I've got my calibration every year. I've got obviously equipment I've got to purchase. I've got a staff wage bill, national insurance to pay, corporation tax to pay, VAT to pay. The general upkeep of the clinic, advertising. There's a lot of pressure running your own business, And then beyond that, I've got to obviously I've got my own personal life. I've got my own costs, living costs, my mortgage, car, fuel, utilities, food, clothing, etc. So and I mean I had a kind of a bit of a spot, and I still got it, and I was just told by a friend to get it checked out, just to make sure it's not possible basal cell carcinoma. But I wouldn't take a picture of it and just find someone online, like Pimple Popper, for example, and email her and say, do you mind just taking a look at this? I mean, I had to book an appointment with the doctor, and it took me a while, but that's the way it should be. So for those people that do reply, to do email us, we always send this polite email, and I think once we do, they actually acknowledge it, but it's a bit not upsetting, but you just kind of makes you scratch your head. Well, why are people responding back kind of with a parting shot like that, insinuating that we're not kind of reputable, because we in the roundabout way that's what they were saying. Anyway, so guys, I understand a lot of you got these online cameras and you want advice, but I think I give a lot of free content. Like with my YouTube, I don't have separate channels for subscription. I kind of just give everything there, and we don't get much monetization on the videos, and you guys will know that, especially on YouTube. There's not many ads. I think back in 2017, YouTube changed their policy where if you have earwax removal videos, pimple popping videos, and blackhead removals, and they actually at the time specified those three genres, they're not going to be monetized as much. So financially, it's not really worth my time in that sense. I don't get that back. And like for this example, this video is 20 minutes, so I've had it originally it's probably 35 minutes. I'm watching through it, I'm editing it, and then spending time narrating it. And whenever I do narrate it, for example, in this case, benign osteonecrosis, I mean, it's good for me in a way as well, because it allows me to just go back to a particular pathology and just kind of read some of my notes, and for my CPD, continuous professional development. But it's a lot of time, then uploading it, creating a thumbnail. It's not a quick and easy task. Anyway, so I just wanted to say that, because we can't just give that online free advice, guys. It's for a number of reasons that I outlined earlier. So this is their right side. This came out so much easier. I just used the right angle correct, went over the top, scooped it out. And it's always their left ear that's the more troublesome, more difficult one. And just lifting this plug up and away. Guys, sorry, I didn't have time to take a still image of this. It was quite a whopper. This procedure was quite a long one, and we had patients waiting area. So just once we cleared it, I had to wipe down, write the notes. But there's that widening again, and there's a little blood blister there, a bit of granulation tissue bottom left, and also right on the floor. So we're just going to spend a bit of time peeling some of the skin. The skin was really, really difficult. So there's that. That's that border where I am now, where the skin is. And when you've got a widening like this, what's difficult is that the skin can't naturally migrate. The natural migration of skin, the lateral epithelial migration of skin. So the skin that lines the eardrum, the outer layer of skin, should I say, and the inner 2/3 of the ear canal, it's a layer of epidermis skin. And as that kind of dies, it moves sideways laterally from the deepest region of the ear canal to the entrance. And then it separates, and it naturally expels itself from the ear. So it's the ear's natural cleansing process. When you've got such a widening like this, the skin gets trapped within the erosion, the crater, and then it can't escape back out. So inevitably they're going to get a buildup of dead skin. And if that skin isn't regularly cleaned, that skin can then get infected, and then just can cause ulcerations of the floor of the ear canal and expose the underlying bone. But again, in this ear, there's no ulceration. The skin is fully lining the ear canal. So I think I'm just going to reach out for the forceps. And I wanted to do this in a dry method. I don't want to use any drops because there is a bit of a crater there. Sometimes the drops can kind of even with my best attempts to clean it all out, it may reside in there, and it's very difficult for the drops to then naturally migrate out. So, I mean, sometimes I do use drops, and it's really, really tough, but here I've managed to do it completely dry without any drops. The skin was a bit annoying, if I still remember it. I think I managed to get a little bit out. But what was happening when I approached it, it's almost like as it was entering, the gush of wind following the forceps was pushing the skin further away. So just come for the suction, the fine end. I think I just managed to tear a little bit away, but there is some skin left, which I'm fine with. I think I have one more go with the forceps. And I managed just to get the jaws either side around it, but that, I think that's it really well. I hope you enjoyed that video, guys.